All right. Hello. My name is Derek Mosley. I'm the director of Marquette Law School's Lubar Center for Public Policy Research and Civic Education. And it's my pleasure to welcome you to our On the Issues program, focusing today on health equity in Milwaukee. Did you know that in 2020, Milwaukee County was ranked 71st out of 72 counties in regards to health outcomes? Did you know that? Number 1 was Ozaukee County. Number 72 was Menominee County, which primarily consists of the Menominee Reservation. Did you know that White County residents are outliving their black counterparts by nearly 14 years? Are you aware of that? The infant mortality rate is 3 times higher for a black baby that is born in Milwaukee as opposed to white babies born in Milwaukee. Blood lead levels were twice as high for black children than their white counterparts here in the city of Milwaukee. Now, Dane County, which is our seat, our legislative seat, ranks within the top 10 of the best counties for health outcomes. But were you aware that the black and brown populations in Dane County actually rate towards the bottom when it comes to health outcomes? I wanted to put together a panel to talk about those stats and other issues which affect health equity here in not only Milwaukee County, but also in the state of Wisconsin. So I want to introduce to you our illustrious panel of subject matter experts. I'm going to start all the way on the end there with Chief Medical Officer for Population Health and Education, Medical Education at the Medical College of Wisconsin, Dr. Mark Lodes. If you can give him a round of applause. Next to Dr. Lodes is Dr. C. Greer Jordan, who is the Assistant Professor of the Institute of Health and Equity and Vice President of Inclusion and Diversity at the Medical College of Wisconsin. You can give her a round of applause. And directly to my left, we have the Secretary-designee of the Wisconsin Department of Health Services and someone I had the fortunate pleasure of marrying. Not my wife marrying, but performing her wedding. Kirsten Johnson. We can give Kirsten a round of applause. All right, so what I've learned from doing my little research on health equity, not only in Wisconsin, but across the country, the higher you are on the economic ladder, the more possibilities that you have when it comes to being as healthy as possible, right? So we refer to this in terms of health equity. So Dr. Lodes, I'm going to ask you first, how would you define health equity?
Well, we have a fairly simple definition, which is getting the best possible health outcomes and top decile care for all of our patients, regardless of their station in life, the color of their skin, the level of education they have, or the accessibility or opportunity they have to avail themselves of health care. At the end of the day, if we're providing highly equitable care, all of our patients across the spectrum are experiencing that highest level of outcomes. And we define that by quality of life and length of life.
Dr. Jordan, is there anything you want to add to that definition? Or?
Well, I think I'll just add some perceptions of that definition that I've
Please.
heard. That health equity somehow means that we're expecting that 2 different people are going to have the exact same outcomes. Well, we all know that that's not necessarily true. There's a whole bunch of circumstances that go into where a person is, but when we talk about health equity, the person at least has the opportunity to avail themselves of the best possible means of them being healthy.
Secretary Johnson?
So I would just build on it by almost simplifying it by saying everyone has access to having the healthiest lives possible. And what are the things we need to do to make sure that that can happen?
Now, I wasn't aware, when we talk about health equity, I've noticed it probably within the last 10, 15 years that people constantly refer to social determinants of health. And it was something that I hadn't heard till about 20 years ago. care which one of you wants to do it, but does someone want to explain what we were talking about when we talk about social health determinants?
Absolutely.
Yes.
I can start, and then, so we look at, and my background's in public health, so social determinants of health are really those social factors that drive health. So they really are dependent on where you live, your access to quality education, economic opportunity, access to transportation, the quality of housing, the housing, or if you are housed or unhoused. Those are all factors that ultimately drive health. And is really what speaks to, if you see those huge disparities between Milwaukee and Ozaukee County, for example, Ozaukee is the healthiest county in the state. Arguably, it's the wealthiest county in the state. They have ample housing, the education system is high quality, and people have access to economic opportunity. So, and then if you look at Milwaukee, we experience really significant disparities between those two counties.
So, Dr. Jordan, how did we get here with the social determinants of health? What took us so long to figure this out? I've only been, I don't know, has it been longer than 20 years that we've been talking in this frame? But it seems like now you hear it all the time. But I remember I had a kidney transplant, and I don't remember hearing that conversation during that time during my medical journey. Is this something? What brought us?
As far as some background for me, 20 years ago, I was an engineer for a motor company. So I'm coming into this relatively new too. My understanding of where the term came from was, I think, the World Health Organization, who was looking at the interventions that we're looking at globally and saying, we're missing something here. And the idea that a person's health is totally up to their choices or the culture that they're in wasn't really getting at really why people don't have access to health and defining health in a broader set of factors than only their access to health care. So that's my understanding of where the term came from. I'll add to it though that you might hear the conversation about social determinants of health or social drivers of health. Most recently, I saw something around the social dynamics of health. So the concept itself is very broad, depending on where you're coming on it. You might be getting a particular slice of it, but it's still this idea of yes, an individual makes their own decisions about things, but your decisions are limited by the available resources that you have around there in those 4 areas that Kirsten mentioned. I would just add the social piece. We're really seeing lately, because this is evolving, how important your social connections are, your connection to your community, those types of factors are too as well in terms of health.
You know, and I think if we look back about a decade ago, the focus of many healthcare organizations, and a big one nationally is Institute for Healthcare Improvement, IHI, that was really, the focus was really on, can we give the highest quality of healthcare delivery? Once the patient is in the delivery system, what's the quality of that delivery and the outcomes? But they realized, at that moment about a little over a decade ago, that should we really be focusing on healthcare delivery or should we be focusing on health outcomes, on health, mortality, quality of life, outcomes at the population level? And when you make that flip and you start saying, what is the contribution of healthcare delivery to health outcomes? It's only 20% of health outcomes. 80% are these social drivers, right? Whether or not you have significant funds and income, whether you have adequate housing, your personal health behaviors like smoking, alcohol, exercise, diet, right? And then the environment you live in, is it safe? Do you have clean water, clean air? So as you look at that 80%, it changes the focus of healthcare organizations as they, and myself as a physician, as I'm approaching my patient, if it's about getting them the best health outcomes, it has to be around that 80%. And so this is the sea change that we're seeing in healthcare organizations across the country, trying to figure out how they best put investments back into that other 80%. That we're already doing the 20%, let's make sure we're doing that great. But it's the other 80% that is, the massive opportunity for all of us to come together around those.
So, Secretary Johnson, you mentioned it briefly in regards to Ozaukee County, because that's where you were prior to Milwaukee and then where you are now. What was it like on the ground in Ozaukee County, at the healthiest county in the state?
I want to add something just quickly to the social determinants of health. I like to also add the political determinants of health, because I think those social factors are often driven by policies and politics, and that ultimately creates the society that we're living in. So there are, we have institutionalized some policies that frankly drive institutional racism that we experience in Milwaukee that have directly impacted people's health, like redlining, for example. But I'll speak to Ozaukee. I always joked with the county health rankings that I was fully responsible for that #1 ranking because I was the health officer and it was all the amazing work that we were doing. But in reality, it was the social determinants. And the challenge in Ozaukee County or in counties that are highly ranked is there are still people who live there who are poor, who don't have access, who are sort of falling through the cracks. And for example, if you look at dental coverage in Wisconsin, Ozaukee and Washington County have some of the least access to dental care for people who are covered by Medicaid or uninsured compared to the rest of the state. Whereas in Milwaukee, we do not ideal dental care, frankly. We have a lot of work to do, but there is access where there's not access in other places. So I think it's important to think about what does health equity look like based on geography, because health equity in Milwaukee is very different than health equity in rural Wisconsin, for example. In rural Wisconsin, you call an ambulance or you call 911, and it can take an hour and a half for an ambulance to get there. That is inequitable, versus in Milwaukee, if you were to call, an ambulance could be there within 5 to 10 minutes, or maybe less.
I want to go back because you brought it up. So you talked about the political influences, and you mentioned redlining. What are some others that are on your top of your mind?
I think so. It's big policy, like redlining, for example, that we know has had a historical impact in Milwaukee and in Wisconsin. There are also small p policies that we don't even think about every day that have an impact. And I'm going to give an example. In Milwaukee, I was the health commissioner during the pandemic. We did some mass vaccination clinics at the conference center. Early on, within the first few days of one of our mass vaccination pushes, somebody called and said, "You're asking for Social Security numbers. Why are you asking for Social Security numbers?" Nobody knew why we were asking for Social Security numbers. It was just on the form. And in short order, within an hour, we threw all of those forms away, printed new ones, crossed it off on the existing forms, and we couldn't print them quickly enough. But that was incredibly inequitable, because if people weren't comfortable with their immigration status, they weren't going to fill it out and they weren't going to get a vaccine. And again, so these are things that we just don't even think about, but it's really important in our roles as leaders and in our roles in communities to ask the questions. Why are we doing it that way? And if we're putting a policy in place, what are the implications? Because in the best intentions, you really have to think through how is this going to play out long term. Yeah.
Absolutely. So we've identified problems.
Yep.
What are we doing to try to rectify these problems, or at least abate or somehow mitigate these problems?
Well, I think the point about policy reform is a really important one. I think the notion that this is going to take more than healthcare systems or the healthcare sector to fix. As we look at, so one of the data points that we've been looking at is we've taken, there are a number of these indices out there. One is called the Area Deprivation Index that was developed at UW, and it basically takes the American Census Survey and the 10-year census data and looks at 15 different factors, social factors, as they impact different communities. And the census survey goes down to census blocks and census tracts. And so we are able to map all of our patients that we care for to which census block or tract they're in. And then we're able to look at the census blocks and say, is this a 10th decile, highly vulnerable community? Or is this a lower vulnerable community, maybe a 1 out of 10 that's in a suburb? And as we look at the outcomes for our patients, we see it's highly predictable and it's linear. 80% of our patients that need a colonoscopy that live in a 1 zone have had it done. 60% of our patients that live in a 10 zone have had it done. And it's linear. So we can predict, based upon where you live, what the likelihood is that you have gaps in healthcare delivery. And so the question for us is, how do we now take that data, understand what those barriers are for someone living in that area that's a 10 versus the 1, and really start to make meaningful changes to how we approach that screening process. We mailed out 20,000 stool-based tests for colon cancer last year to some of our most vulnerable communities, regardless who's living in those communities, the most vulnerable communities. And we had over 5,000 of those come back, and we diagnosed a few hundred patients with colon polyps, and we had a handful of individuals that had colon cancer that they didn't know they had, and are here today because of it. So those are the types of real kind of grassroots things that we can do organizationally, and if we work together with communities in really engaging together, I think we can do even better things, moving forward.
So what concerns me, so I travel around the country and I give speeches on unconscious bias and DEI type stuff. And I'm seeing there's been a lot of pushback on those types of programming. And I'm wondering, how do you see it, Dr. Jordan, in regards to being the Vice President of Diversity and Inclusion at the Medical College? Are you seeing that same pushback when it comes to the social?
I'd like to go back to the previous question a
Yeah.
little bit, because I'm looking at it, I'm not a physician, as I've kind of alluded to before. I look at organizations and I look at systems. And pardon me as I geek a little bit, but what we have here is what's called a complex systems problem. Even when we talk about these 5 social determinants of health, they all interact with each other, and there's a lot of players involved. So sometimes I think we have to kind of step back and say, what is the definition of the problem that engages all of these players, where they can see what their interests are so that they will engage in solving some of these larger problems. So I think it's important to kind of step back and see that healthcare is not going to solve the problem. Government's not going to solve the problem. A large employer foundation isn't going to solve the problem, because it's many problems that interact with each other, and each player needs to be engaged in their way that they can contribute to address all of these problems at once, so that we have the healthy state that we want. And the interest varies. I've been very involved with the the Metropolitan Milwaukee Association of Commerce, who recognized 8 years ago that if we didn't resolve the health and the racial inequity issues in Milwaukee, we weren't going to have enough employees to run our businesses. That got them very engaged in the Region of Choice initiative to make Milwaukee an area where people of color want to come and live, work, and play. But we had to come at it from an angle that they can influence. So I think that's just an important context to this. When we get to the question about DEI, and I say DEI with air quotes because 15 years ago, there wasn't a DEI that I knew of. I was a faculty in the diversity management program at Cleveland State University, and it was maybe called diversity and inclusion, or it was called more broadly in the organization sense, diversity management. And the focus was, how do we get a workforce with people who are individually different to work together towards something that is collectively for the good? And that's what it was about. And the fairness part of it, I have to say, amongst the top management scholars, they sort of avoided that. They sidestepped around that. In the last 15 years, though, with changes in Title IX and the people with disabilities movement, changed that fairness part to front and center. And I will say that most business organizations and some institutions were not prepared for that shift. They were not prepared for it. And so what I think we see now are people now having to step back, and whenever you get too far ahead of yourself, sometimes you have to step back, and I think we're seeing institutions, corporations, stepping back and saying, wait a minute, what exactly am I trying to do here? And how do I frame this in a way where my customers and my stakeholders and my shareholders understand why we need to do it for the business? So I think in a way, it's difficult. It's hard to hear some of the name calling and really disrespectful discourse that is going around online that is very personalized, as opposed to stepping back and saying, wait a minute, what do we accomplish here that's for the good of everybody? But I tell you, those conversations are going on within businesses and industries. Some of the ones that you might have seen in the news, retracting from but I think many of them are taking that opportunity to step back and be more thoughtful about it than reactive about it.
That's my biggest concern, right? Because we finally identified, here's all the problems for health equity throughout Milwaukee and throughout the state, and now I'm scared of backlash of what we're seeing.
This is a cycle. I say now, I'm old enough to at least have seen the cycle. I remember back in Detroit, I'm from Detroit, I saw the first cycle of affirmative action. And literally Ford Motor Company, in order to meet their they didn't call it diversity then, but their equal opportunity targets, sent a bus into downtown Detroit and said, get on the bus if you want a job at Ford. And so that was how unrefined the approach was. So it's, I'm not going to geek out too much about.
No, you're amongst geek friends. Yeah, we're all geeks, so you're welcome. Dynamic systems. But sometimes if you look at a thing in 2D, it looks like you're doing the same thing over and over again. But if you flip it 3D, I was just talking to Raul Uria in our precision medicine, and he's talking about if you flip it to 3D, all of a sudden you see a lot of stuff going on. And it's been the same with this perpetual challenge we've had in this country around how are we going to become a country of everyone, not writing women and people from Africa out of the Constitution. How do we go back and create this? It's been a challenge, since the beginning of the country. We cycle around, it seems like we're going back to the same thing again. You flip it in 3D and you can see the greater depth of knowledge we're bringing into it. So for example, social determinants of health. I don't know if that being on the radar more than 20 years ago and as the end aim of what we're trying to do here. And I think when we talk about health and people's access to being as healthy as possible, I think that's something that more people can kind of join in around. So I'm hopeful, from that perspective. But I saw it seemed like that came on and there was a backlash against that. So then we started doing diversity training in organizations, and I was at Fort when there was a lawsuit about that. This is far before this. So, and guess what? The key problems we talked about here today still stay. We still need to do something about it. We get back, we learn, and we go at it again because we have to address these problems. Anybody else want to elaborate?
I was just going to say, I think that that is the point. So at DHS, where I am now, the Wisconsin Department of Health Services, at the end of the day, all of the work we're doing is to address health equities or inequities. How do we do our work to assure that everyone in Wisconsin can live their healthiest lives? And the legislature is, they came after the UW system around equity, diversity, equity, inclusion, and now they're coming after the agencies and the administration. And it's to your point, it's just a different version. We are trying to be careful about how we frame and word things, but it's about framing too. It's about the words we use. We are going to continue to do the work, regardless of how the legislature views it, because it is critical to our mission of achieving healthy lives in Wisconsin. Yeah.
I think that connection to mission and to your business, and seeing those connections between the DEI strategies and the outcomes you're trying to achieve for your organization is really critical for the C-suite to understand that. And I think where it just becomes, well, this is an ideology that we're supporting, as opposed to this is a strategy for us to get to our goals as a corporation and as an entity. I think those two are, when you see groups backing off, it's, I think, because they haven't made those connections. For us, that 20% of folks who aren't getting their colon cancer screening, that's an opportunity for us to improve our quality, to connect in a different way to our consumers, right? To bring in more people into our system and to succeed as an organization. But we can't do that if we don't have an inclusive environment, a diverse environment where you can go and see someone that is from your community, in your community, that understands you and your healthcare needs. So those things and that connection, to your mission as an organization, I think organizations that have created that really strong connection there and understand it in those terms are not backing off from it. They're actually like us leaning into it.
And I know we spend a lot of money on treatment. Are we spending as much time and money on prevention? Or is there more room for us to spend on those two issues?
That's a loaded question. So arguably, no, we do not spend enough money on prevention. And I think the challenge in prevention is, and this is an age-old challenge in public health, is if we're doing our jobs well, you don't know that we're doing it, right? We're preventing illness. We're preventing people from living in housing that is poisoning their children. We're preventing people, we're preventing child deaths, we're preventing maternal deaths. So it's hard to measure that return on those dollars on that investment when it's not visible. But I think twofold. One is we are working really hard to talk about the data and do better storytelling on the prevention end. I think about, when I was like in fourth grade, I remember submitting a poster for a poster contest about like don't smoke, right? We've come a long way. We now recognize that people smoke because they are exposed to marketing and they live in environments where they're smoking, and it's really the policies when the Clean Air Act went into Wisconsin. Guess what? The smoking dropped. Teenagers stopped smoking. Our smoking rates have declined significantly, and it was a policy that drove those behaviors. And when we realize that, we have so much more power, and I think it's really important just to continue to focus on sort of upstream. What are the factors or policies that we can put in place that will help people have healthier lives, because the behaviors are being driven by those policies. So yes, I don't think we've spent enough money on prevention. The flip side is, I think we all want a robust healthcare system, and we all want to have access to quality healthcare, and that does cost money. So, our healthcare system in the United States, you could say a lot of things about it, but it does cost money, and it saves lives. You're a kidney transplant, right? Yeah. So again, I think there's a balance, but I do think that we need to shift towards prevention. And if we do well on the front end, then we're going to actually pay for less disease on the back end. Yeah.
Anyone else?
The challenge, it's not an either or, it's a both and.
Yeah.
Okay.
Because again, it's a complex system problem, so you have to be doing both ends. So I use anybody remember Y2K? All right, that was a big, the sky is falling. But industries, the government, everybody invested in fixing that problem. Now, did we stop investing in other business growth at the time? No,
of course.
We did both. As a result, as I recall, it was one ATM in Japan that went highway. And then the pundits came in, why did we spend all this money? It's like, to prevent, that was success. So I think we have to start to frame success for people a little differently so that they can understand what that ounce of prevention worth a pound of cure looks like. So I agree, it's a languaging piece. And remember Y2K. There are many times where we've come together to avert disasters by investing in both areas at the same time. The question is, where is the wherewithal to invest across that sector at the same time so that we can see the fruits of this 10 years from now?
I think everyone in the hall here recognizes that we spend more per capita on healthcare than any country in the world, by far. So it's not that we aren't spending money on healthcare today. And granted, having more of the dollars shifted that we are spending on healthcare into screenings and immunizations and preventative care is an important piece. We just talked this afternoon about this other 80%. So actually, having improved housing improves health. Having some ability for a family to generate some generational wealth and get out of poverty improves health, right? Having cleaner air, water improves health. Having access There are so many census tracts in Milwaukee that don't have any access to fresh fruits and vegetables, zero at a grocery store. So, improving those things improve health, but we don't count that as healthcare, expenditure, and we don't count it necessarily as prevention. But if we do really well on that side of the ledger, we're going to spend less on healthcare. This per capita problem we have in terms of our healthcare expenditures can get better because we're going to have less disease. But we have to start thinking like that. And we have to start thinking about those things that we're doing in those other sectors as really accruing to benefit in prevention.
Is there anyone doing it well? Is there anyone that we can look at and say, they have this formula, it seems to be working in Boston, or it seems to be working in New York? Is there someone out there who seems to be on the right track, or are we all still trying to find our way?
I think there are places doing it well. I think the United States is unique in our healthcare system. So we spend a lot of money. It's not exactly a free market, but it behaves like a free market in some spaces. It's very expensive. We've got intermediaries all over the place between PBMs and insurance companies. So it's a really dynamic and complex system that is driving a lot of those costs. I think we can look to other countries as being successful. I mean, certainly if you look at Scandinavia, if you look at Greenland, there's a lot of investment on the prevention side, and also access to care is universal, and that makes a significant difference in healthcare outcomes. It's hard to compare the United States to those populations, though, too. Those populations are very homogenous compared to what we have here in the United States, and I think that's an important note that often gets forgotten when we're talking about access to universal health care, for example. There are places that have done complete overhauls of their systems, like behavioral health in Massachusetts. They're seeing some really positive outcomes, and what they're looking at is addressing families' housing stability, access to nutrition, quality health care, social connectedness, and lo and behold, kids have better behavioral health outcomes when they're coming out of high school. So I think we really have to think about what are the investments as communities, as government, as businesses, and what are the priorities, looking at data that we know will drive better health outcomes. So housing is a big one, education is another, transportation. Those are the things that we know that if we invest in on the front end can really have positive health outcomes on the back. Yeah.
So I would say that different sectors have different strengths. And so there's things. So for example, Medical College of Wisconsin, and in fact Marquette, is a member of the Coalition of Urban and Metropolitan Universities. And there's what we call the Anchor Learning Network that's part of it. And we get together monthly and learn what University of Pennsylvania has been doing in terms of this place-based investment or engaging the community around health, or Case Western Reserve, where I got my degree from, and Cleveland Clinic, creating a evergreen business that is employee owned in order to employ people within a really underinvested area of Cleveland. So there are models like that out there. I think what's been important is to bring together these coalitions so that we can exchange ideas, and we can invest in the ideas, these different areas from our particular areas of strength, as opposed to trying to do something that was someplace else that we don't have the capacity and capability to actually execute on. Freighter is part of the healthcare anchor collaborative, a healthcare anchor network, and you could probably say more about what they're doing there, but there's a bunch of healthcare systems that are together to address some of these social determinant type areas and exchange ideas and do the things that make sense in the particular context that they're in.
Yeah, and I think since in the last 5 years, where there's been such activation, I think, of healthcare organizations, industry, around this topic, that ability to come together in consortiums, share ideas and knowledge and learn from each other has really been a meaningful activity for us, and it's certainly given us lots of hope and ideas of things that we can do. I think we've still got that change that we're doing that is institutional, that is specific to our means and our people and our outcomes that we want to help achieve with the community. But it's going to take something bigger. That big C change that needs to happen really requires that collaboration. And within that context, I think every one of the organizations involved is probably going to need to make some social investment, right? A social investment fund that's going to help to really fuel that. And we've got a number of examples. We've got the Deer Accelerator that we're doing with the Bucks, and we're raising dollars to try to invest in local communities and really address a lot of these things that really ultimately affect health, but are these really social drivers that we talked about. It's those kind of things where you have government, private industry, our patients, public citizens coming together, really wanting to make change. That's where cities and communities that have really done well in this have that type of model and that kind of connectedness. And you can look, and there's a Blue Zones org that is doing this around the country and really facilitating this. It's expensive. It takes a lot of investment, but they have some really great examples of some of the improvements that have been made through that effort.
Dr. Lodes, could you elaborate on Blue Zones for those who aren't familiar?
Sure. So this began with this observation that there are certain communities and places in the world where longevity and general health are improved or greater than other areas of the world. And these were termed kind of blue zones, just the right confluence of factors that were resulting in, for one reason or another, a longer lifespan and greater vitality. And so there's an organization that has sprung out of that has really analyzed what those factors are. And they get to a lot of the social drivers of health, as well as healthcare access and lifestyle, and really engage communities in saying, how can we emulate that in our community? How can we understand the current state where we are, what the current state in some of these blue zones is, and then how can we learn from that and migrate our performance and our outcomes to what we've seen in these areas of the world?
Now, I have a few more questions, but I don't know, where's Hillary? I want to open it up for questions from the audience, because I've seen a lot of heads nodding during the conversation. And we'll take some questions right now, right up front, please. We're going to bring in you a mic, Michelle.
Hello, everyone. I'm Michelle Ford. Dr. Greer, I think you and I have been on a panel before.
Yeah, right.
At equity something, I think for the National
the
Association.
National Association of Health Service Executives.
And I know that I got an honorary degree from the medical college a few years ago in humanities. So good to see you all. Just have a question. I've been consulting for the past 5 years nationally and working in other markets. I met with you too, Ken. The one thing I'm seeing, that's occurring is that, the ecosystem, the entire ecosystem is being leveraged, right? So all the players, when we define healthcare and the players of healthcare, who's leading and who's at the table. And I see in other markets, North Carolina, Arizona, California, Colorado, that they're investing through DHS and policy leaders in partnership with the community, with community-based organizations, with FQHCs and all of those others to come together, identifying those problems, building resources and tools collectively to address those challenges. And so I'm just curious about if any of that is occurring in our market. I know many of them have been leveraging 1115 waivers to do some of that, but just curious about where innovation is occurring in our state, and do you see it in the future for us to have to achieve something like that, particularly around expansion of Medicaid?
Absolutely. I'm glad you raised the Medicaid and 1115 waivers. So for those who are unfamiliar, well, Wisconsin is not a Medicaid expansion state. We're one of 10 who have not yet done it. It has been proposed in the governor's budget over the last few biennia, and it will once again be in the biennial budget. We are framing it differently, however. We're really trying to think about, in terms of Medicaid expansion, we're trying to message around the fact that we actually sort of did a quasi-expansion in 2014 in Wisconsin. We covered people up to 100% of the FPL, federal poverty level. on the backs of our own taxpayers. So Wisconsinites are paying for that expansion. And so far, we've spent $2.4 billion in Wisconsin. That would have been covered by the federal government had we expanded up to 138% of FPL. And the reality is that we would have a lot more money coming into Wisconsin if we expanded Medicaid. So we would get a $1.6 billion bonus on the front end, and then almost $300 million a year to spend essentially on healthcare. Previous budgets have really dictated how that money would be spent, and largely it would go back to healthcare. We have sort of said, let's just expand Medicaid and let everyone duke it out on terms of who's going to get the money. At the end of the day, if we were to expand Medicaid, we'd have a lot more flexibility in being able to pay for food as medicine, as providers could prescribe medicine for people who've had surgery or at risk of some acute illness, and the food could be delivered to them. Medically tailored meals could be delivered. We could expand for housing vouchers. We could pay for housing on the front end. We could pay for security deposits, we could pay rent. And we're doing this to some degree, but we are quite limited because we're not an expansion state. So it has been challenging. The other piece that we are working on in DHS, and I am very hopeful that this will have an impact broadly across the state, is thinking about within DHS, how do we spend our money? And we need to be more strategic in how we invest in communities. So not only pushing money out the door, but assuring as we push it out the door that it's going to places and organizations that we can support in using the money in a meaningful way, that it's a collaborative effort, that we're bringing everyone to the table collectively. I mean, for example, in maternal and child health, we have spent millions and millions of dollars in Wisconsin on trying to address those disparities. One component, 20%, is about bias in healthcare, that women aren't getting quality care when they're Black and brown women and they show up to give birth. If physicians aren't necessarily listening to them, providers aren't listening, there's some issues within the healthcare space. But we have also spent a lot of money trying to address the external factors, so the social factors related to those poor birth outcomes. It has to be more targeted. We have to really think about where is it that we can spend that money. It's not cribs. It's not pack and plays. It is not working. It's not pushing breastfeeding. That's also not working. We have to be very strategic in how we invest those dollars so that we can actually move the needle and save people's lives. So to your point, I think there is promise, and we're trying to be very thoughtful and strategic about not only the dollars we're spending and pushing through, but making sure that as they go into the people's hands, that they can be spent in a meaningful way and have an impact. Yeah, and then Medicaid expansion.
A great thing we're doing in this community, and I think, we probably don't recognize it the way that, but many of you may know of the Milwaukee Healthcare Partnership.
Oh, it's phenomenal.
I mean,
yeah.
We talk about this on the national stage at meetings, and, people are taking notes. Like, this is a Milwaukee idea that's a huge success, and it's the healthcare organizations in the city came together along with the FQHCs and public health, and they created an investment vehicle to try to better coordinate care for all of our patients. And so those federally qualified health centers do primary care, but they have no specialty care. Every single one of the three health systems that are involved, ourselves included, we make streamlined access for all of their referrals, do it electronically, do it equitably across the health systems in terms of the distribution of those patients to that access. Everything that happened with that behavioral health center and the staffing and the behavioral health ED that went off the county grounds and into Milwaukee, that was facilitated all by Milwaukee Healthcare Partnership. They have so many programs. Go on the website, take a look. It is a place where Milwaukee is leading, and it's really the result of the big systems saying, we have problems in the city that are bigger than any one of us can solve, and we need to come together with others to try to help solve it. It really has been a shining light.
I would also say that the Milwaukee Healthcare Partnership, public health is also at that table. But for example, I think today Aurora announced that they are forgiving liens against houses for medical debt. That is largely driven because of the priorities coming out of the Milwaukee Healthcare Partnership. It is really a shining light in Milwaukee.
Yeah, I'd say on the academic front, the Advancing Healthy Wisconsin endowment has been responsible. I have to look it up here real quick, Claire. A $20 million investment to improve behavioral health outcomes through working directly with folks on the ground who are involved and invested in these issues, and getting getting money, resources, and knowledge into those folks' hands. I think a big change that needs to happen in academia, and it's underway, academia had thought, hey, I go and I study something, I publish a paper, and I get it in a Tier 1 journal, and I'm done. That doesn't work anymore. I mean, we have to, academia has to shift from, we're losing the battle of public opinion about even the value of higher education. So anyone who cares about higher education also needs to think about, how do we help the public understand what we do by enabling the public to take advantage of the knowledge that we create. So the projects through Advancing a Healthy Wisconsin Endowment are helping us do that. Is it perfect? No, because that's not the model that higher education had traditionally engaged in. So we're having to learn. Dr. Stacy Young, who's now over our community engagement function at MCW, she's doing a fabulous job in collaboration with our new Thrive On facility and the Thrive On collaboration to say, how do we get what we're learning out into the community, and how do we stay open to learning from the community so that we're coming up with better solutions and better ideas so that when some money comes along, we've got an idea, we got a shovel-ready idea ready to do that. But I think what you're alluding to, we do have a bit of a pie problem. You know, and when the resources are scarce in the pie and people start fighting over the pie, we've got to expand the pie, and the policy pieces are those things that help to expand that pie. Yeah.
I want to ask about food. A couple of you have alluded to different aspects of food and nutrition, and Judge Mosley is a well-known foodie in our community. I would argue that food is one of those foundational access points that's so important. So I'd like your observations and comments on that, and what can foodies do to help in this regard, and what can the rest of us do? And do you agree that food is one of those foundational basic items that needs to be addressed?
Well, definitely it is foundational, right? And as I'll put on my physician cap, I'm an internist, internal medicine, and pediatric boarded. And you know, that everything we eat that's processed is very high in sodium, is devoid of a lot of the nutrients that originally were in those foodstuffs. And you know, essentially are just not healthy for us, right? And what you see with those processed food is that the shelf life of those foods is much longer than our whole foods, right, and our fresh foods. So in a world where we've, you know, created an environment where those fresh whole foods and fruits and vegetables aren't accessible, and where we've created now family dynamics where we're eating in ways that is really more in this processed food and, you know, devoid of many of those whole fruits and vegetables, we've created, you know, a cycle of hypertension, metabolic syndrome, diabetes, obesity. So fundamental to this is without having access to the foods, you can't even start to try to correct, you know, the diet. And so getting to a point where we have those whole fruits and vegetables, they should be less expensive to buy than the processed foods, right? I mean, right? We want to kind of, we need the economics and the availability to be in line with the goals of nutrition. If we can get that to happen, we've got a fighting chance.
And to kind of piggyback on that, that's one of the reasons why if any Saturday, at 9 o'clock, if you show up at the Fondy Farmers Market, you'll see me there at the Fondy Farmers Market. And the reason why I bring that up is because that, minus that location, that is the food desert that you mentioned. There is no fruits and vegetables in that area. And the thing I love about that market is they take EBT,
Yep.
Yeah.
right? And there's a lot of farmers markets that do not take EBT. And so they make it easy for people who live in the community to get to those locations, get fresh vegetables, fresh fruits. So that's my shout out to Fondy. But
Well, and I would just add, I mean, I think food is fundamental. It's a social determinant of health, access to nutrition, quality nutrition. 20% of the people enrolled in Medicaid in Wisconsin who are also eligible for SNAP, for EBT are not enrolled. And so that's one of the things we're trying to look at too. There's no wrong door. How do we make sure that people who are eligible for subsidies around food are enrolled in those programs? Because they're available, and the intent is that people have access to food, frankly, so they're not hungry. Yeah.
20% statewide?
Statewide. Mm-hmm. Yeah.
Okay.
I wanted to offer one more unique highlight in Milwaukee in terms of activity. There was an initiative in 2018 that started at the Wisconsin Public Health Association around declaring racism as a public health crisis. And I think that, and from that, then the city, the county, and beyond have adopted that resolution. And there is a faculty member at the UWM Zilber College of Public Health and some colleagues who's working on an evaluation of these initiatives around the country. So I think, and the report's not done, but I think that it of course varies in terms of how effective locations, municipalities, organizations are in creating change. But I think it speaks to some of this broader context of the conversation in terms of how we think about health. And so that, I just wanted to kind of give a little shout out for that kind of work as being important when we think about all the kinds of work that we could be doing.
That was poetry to my ears. Amazing. And that's where we need to go, in my humble opinion, in terms of, hey, we are all created by the very blocks that our own moms ate when we were in their respective wombs. And so food is where it's at. Food is what we're made of. And so going back to how we're going to address this as a state, I guess I'd like to know, from a Medicaid expansion standpoint, what is it that is going to help us win that and not be one of those 10 states? What policies can be adopted to encourage that? What can citizens do? And secondly, we talked about the EBTs and SNAP benefits. So FMIC just came out with an entire kit, right, for food as medicine. And can the different stakeholders that were just mentioned, many applaudable ones, come together at least around this absolute critical building block of you and me and everyone in this room, and how?
So the governor's been a huge advocate for all of these things. I mean, he's truly pushed Medicaid expansion and is very passionate about health equity and equity broadly, and how do we address it in a strategic way. To be totally frank, Medicaid expansion would pass if we could get it to the floor, and it's the assembly. So talk to your assembly, to your representatives. It would pass, and it's just stuck with the speaker. Yeah.
We need to get this into the schools too. So we need the school lunch programs to reflect healthy foods, and we need to teach nutrition, and we need that to help drive families to eat healthier and provide ways for them to get access to the whole fruits and vegetables.
We haven't really addressed accessibility. I'm concerned with the consolidation of the healthcare systems here and in Eau Claire, Wisconsin, where all my family is. But, you know, if I want to use, you know, a walk-in service, it used to be fairly easy. But now you look at the map of where you would have to go if you need a same-day appointment, and it's outlying. And I don't know of any in my particular neighborhood, which is near UWM. So I think that's a concern too. People, we don't have those street level clinics anymore, and we don't have that intermediate care that you can get. And I do know about the one at Fiserv. Okay, but I think that's a real problem for people to know they need to see a doctor and can't get in to see the doctor. In my case, I needed Paxlovid. The telemedicine people sent me for a test I didn't need, and I had to find someplace to get it before I could get the script written. And those were all outlying suburbs.
I think that local access is really important. I think health systems do have the, both the opportunity, I think the duty to make sure that we've got centers that are accessible and nearby. The other is that virtual, which came really into being. Medicare and our insurers did not pay for that before the COVID pandemic, and that is at risk of going away at the end of this year. I think there's a balance there. You can't do everything virtually, but that virtual option, we don't want to see that go away either. That's something that, as we look at some of the things we've been talking about today, transportation, right, is one of these social determinants. And if I can't get to the clinic that I need or the specialist, at least I have a mechanism right now for that to be done virtually and for me to avail myself of care with a professional. So, we need to, I think, advocate for that as, a continued benefit, on the national level for that virtual care.
I didn't need the test that I was sent on that drive for.
Yeah, I mean.
Well, and I would argue that's small p policy. Why was that policy put in place? I mean, there are policies that are huge barriers to people, and I'm not going to name the health system, but personally experienced, if you're more than 15 minutes late, they're not going to see you. Well, if you're on a bus, there's no way. I was late because I was in a meeting, and I can reschedule. But if there are other factors, and those are small p policies that healthcare systems are putting in place. And I'd go back to the healthcare market issue.
Mine was an interpretation of the policy.
Yeah.
But missing
Sure.
Yeah.
Hi, good afternoon. My name is Millie, and I'm with Employ Milwaukee, the workforce board for Milwaukee County. And congratulations again, Dr. Mosley.
Derek's fine.
Congratulations on your award today.
Thank you.
Thank you so much. So my wheels are just turning and turning and turning. I know Outreach Clinic, they're doing some upgrading at their clinic to get some new dental stuff in there and other access for those who don't have insurance or may need that. Also, City on the Hill has just done some upgrading. So I think about when the pandemic happened, we did what was called the Community Resource Navigators. And we paid those navigators like $20 an hour or something to keep organizations and agencies afloat and functioning so that we can have the food pantry, so that we can have health care, so that organizations can function, you name it. Is there a way for there to be some collaboration that we see it even as people are telling people get out to vote, right? Is there a way that we can have navigators that go door to door, that go neighborhood to neighborhood and tell people about the resources and opportunities that are available? Some people are afraid, some people feel isolated because they don't have access, but if there's that community link that somebody's coming to my door and say, hey, not just, tell us how many people live in your house, but also there's a clinic up the street if you need this. Also, if you need to get, a SNAP or something that you need food, you need to go to a farmer's market. How do we get the coupons for the farmer's market? Is there a way that there could be some collaboration and some dollars put into having those navigators that could go throughout the community and be that link?
So we're investing in this today. It's our community health worker model. And it is all built on navigation, relationships in the community. Our community health workers are going out to the individual's home. These are not individuals that are trained in healthcare. This model exists across the nation. Lots of research done on this. One of my colleagues, Dr. Leonard Aghetti, has published a lot on that over the years. But what they're doing is fundamentally what you're describing, going into the home, understanding the needs, doing a social determinants of health screening, taking a look at, what is the home environment like? That air conditioner's not working. They need help with some activities of daily living, but they have no one here to help them with that. Their insurance is about to expire. And really navigating them through those needs, connecting with social workers on our team, nurses. I think we can do a lot more of that. I think there's a way to start connecting. I would love to have a discussion with you offline about how we start connecting the community of these individuals that many of the health systems have and many of the clinics have. They're doing this work into becoming better at what they do, not duplicating services, and really getting the best outcomes.
And I think the other piece of that is institutionalizing the idea and the sort of certification is not the right word, but acknowledgement of the value of community health workers and doulas and other professionals who, frankly, we can't pay through Medicaid. So that's an advocacy we're doing at the national level, that they should be included as a designated healthcare worker so they can be paid through Medicaid. And then we're also doing advocacy at the state level. So again, the governor had it in his last biennial budget. It will likely be there again, but that we can pay community health workers with Medicaid because they provide it's tremendously valuable, and it also ultimately reduces healthcare costs.
Well, we have reached our time, so I would like to thank Dr. Lodes, Dr. Jordan, Secretary Johnson. If we can give them a round of applause for their insight. Thank you all for coming today. We appreciate it. We love seeing you here. Other programming coming up, we have our Marquette Law Poll that will be coming up first week in October, the newest poll. So please join us for that. And those of you who are lucky to get in for the Latino Heritage Dinner. We'll see you on October 6th. But thank you all for coming.